We were fortunate in that we did integrate 4 years ago, before some of the current financial crises that have occurred that have affected cardiology groups. We had the vision, and some of the leaders in our group had the vision to see that there was trouble around the corner. And I think a lot of people have expected corner around the trouble for years, but may not have prepared very well for it. We had the feeling, and have since been proven to be right, that governance was more important than payment. And if you're going to spend time working on your payment and your compensation formula with the hospital, you should probably spend 3 times the amount of time on your governance system. And that has rung true not only then, but now. We still see struggles in governance among groups that have been integrated for 3, 4, 5 years. So it's those relationships, it's that communication, it's that function of trust in the integration that makes it so difficult, and that's why we think governance is so important. I think that if there's one thing that we've learned that's tough, as hard as we have worked on governance, we never expected some of the issues of HR, because hiring is just much more difficult for a cardiovascular group when they're employed by a hospital. You then go into a completely different system and structure of governance when you're employed by the hospital, and you can't just say, hire that echo tech tomorrow, hire that secretary tomorrow, hire that assistant. It's much more difficult, and you have to pay attention to that, and you have to set up systems of communication with that governance structure in HR. We spent an hour yesterday, as you know, in 3 different sessions going over the potential for horizontal integration and what does the 3- and 4-man group do, and we're going to spend more time this afternoon talking about the 3- and 4-man group and where do they fit into this as opposed to the mega group with 25, 30, 40 cardiologists. We see potential in alignment before. Sometimes a hospital who has 3 or 4 different groups of cardiologists who are working there, one group may be 10, one group may be 12, one group may be 6. Sometimes it's good for those groups to communicate before. Do they have similar cultures? Do they have similar goals long-term and vision? If they do, then a lot of times it's best for those groups maybe to work in tandem or at least communicate before going to the hospital. They may have advantages in numbers like that.
What is a practice after integration? And I think that's a great topic, and I think it's the main issue that physicians are confronting today. But really it's a very simple answer. The issue of what the practice looks like before integration should be no different than after integration. Physicians are really worried right now how they are going to relate to the hospital. That is not the issue at all. The issue is how do the physicians relate to themselves. Internal governance is really going to be the biggest challenge physicians face. Physicians tend to be independent people that don't work together well as a team, and as we go forward to provide higher quality and lower cost care, you're going to have to work as a team. You're going to have advanced specialty care. You're going to have to share responsibilities and give up some responsibilities. The hospital systems really don't want to be involved in that. If you're a hospital CEO and you have a very, very functional, well-run group that works together, the interaction is very simple. You sit down with the CEO of the group, you go over the budget, find out what you need, and you go forward. So what I see the focus now is, and most groups are worried, gee, is the hospital CEO going to tell me what to do? Yet when you talk to the hospital CEOs, what they're worried about is what's going on in the group. If you're a hospital CEO and you integrate with a 20-person cardiology group, you want to be sure that you're not going to have 20 cardiologists come knocking on your door every time there's a problem. It's their worst nightmare. That's one of the reasons they don't want to integrate. Some of the CEOs are being even a little bit more sophisticated. They're demanding, as part of the integration deal, that compensation models have been worked out, and they're even demanding governance consultants come in. They do not want to be in the physician management business. They did that years ago and it was a disaster. So how does it work after integration? It should work the same as before integration. The only advantage, I think, for physicians is, at least in our group now, we can really practice medicine. We're really focusing on quality initiatives, outcome analysis, data systems. The struggle with private practice was Medicare was 60% of our business, and we just couldn't rely month to month even on what our fees were going to be, and you can't plan quality programs if you keep getting slashed by 1,000 paper cuts. So long answer to a short question, but it's simply put, how do you get along now is really how are you going to get along after integration.
Well, I think we can take that theme we've been talking about all along with the fee schedule hits, the payment reform issues, the models of care that we're going to be delivering, and take that now up to the current status of the integration of practices. And I think what we're seeing across the country is that we realize we must deliver health care in a different way. And whether or not private practice cardiology per se is dead, I think the crystal ball still isn't quite clear on exactly how that's going to evolve. But there is no doubt that we need to partner with our hospitals. And in order to redesign patient care delivery models and payment reform, that redesign needs to start in our local communities between our hospitals and our physicians. I think that is what's driving a lot of the cardiology practices. In addition to the issue we have with the physician fee schedule, there's no doubt in the integration model that the rationale as to why many practices initially look at integration is because of what we call the provider-based reimbursement component. PBR, as we like to refer to it, is that process where we can have the same test on the same machine by the same technician done, and yet the hospital gets paid 3 to 4 times more than that. So I think physicians, rightly so, are migrating towards that payment model or a reimbursement model for them. But as a part of that, we need to be very careful with the governance structure of how the integrated models work and how we're really going to partner with that. So I think as groups go through the integration process, they may start for the financial reasons, but most of them end up for the right reasons, which is it gives the physicians the opportunity to not just govern their practice, but to actually govern the product line within the hospital, which allows for great patient flow and throughput in the hospital setting, which has been sorely neglected. I think it will also allow us to care for our patients much more cost effectively because now we're truly a team at the table with the hospital as we look at integrated models. So I think governance is very important. Obviously, physician compensation is very important, and the delivery care model for our patients are probably the triangle of why integration continues to evolve.
For those groups who have chosen so far not to integrate, and clearly some groups say they will never integrate, one of the trends that we're seeing is some of those groups are retrenching, and it's almost a panic mode. They're not hiring new physicians, they're laying staff off, they're reducing benefits, reducing pay. It's a complete retrenchment. And a very wise man once said, "You'll never save yourself into prosperity." And so I'm of the opinion that if you're not going to integrate, or if you're in between, you have yet to integrate, you still need to attack the business. You can't simply retrench and expect to improve. You can't wait for the savior. It's not going to happen. We know that we've been dealt a hand with significantly decreased reimbursement, lots of other issues to deal with. That's probably not going to change very dramatically. So we have to learn how to manage within that environment now. And you're not going to do it well by trying to shrink your practice. You've got to aggressively look for other revenue opportunities, for efficiencies within the practice. Clearly there are lots of opportunities for efficiencies. And of course managing your overhead effectively. And I think Paragon can really help identify some of those issues that can be addressed. So after the integration, the environment changes fairly dramatically, especially if you've chosen the cardiovascular service line management choice. And that's where we have the leadership now, the physician and administrative leadership, to manage the practice effectively. Now we're going to manage the whole cardiovascular service line, and that brings into play the cath lab, the EP lab, non-invasive diagnostic centers, perhaps the CCU and step-down units, and perhaps even the cardiovascular surgical program. That's a whole new ball game and takes a lot of expertise. So it's a big transition. You need to be prepared for that. And that's where we think Paragon can provide some real insight into what those demands are and how you approach those demands.